Hello, my name is Klaus Buergelt. I'm a veterinary pathologist with the College of Veterinary Medicine, University of Florida, Gainesville, Florida. I'm delighted to be here, and I would like to thank the C.L. Davis Foundation for having me here, and also the Armed Forces of Pathology, Institute of Pathology, to make this possible. May I have the first slide, please? Will be equine pathology, and I have organized this talk along age groups. I have I'm focusing on 3 age groups, the neonate, the foal, ranging from day 1 to day 30th, the juvenile horse, and then the adult horse. I've also organized the presentation along topics, and this is a list of the topics that I will be covering in a systematic fashion with primary examples for each of the organ systems. I would like to start with the neonate, diseases of the foal, and have as the first presentation some examples of congenital diseases. The best known of such congenital examples is associated with the heart. The number 1 developmental defect is known as ventricular septal defect, and mostly it is present with the membranous portion of the ventricular septum. In this particular instance, we also have a defect associated with the muscular portion. And then depending on the size, there may be signs, clinical signs, or not. If the situation is as depicted here, there likely is an exchange of blood from left to right, and then later probably a reversal from right to left, and that will create cyanosis, and such an animal particularly will have evidence of murmurs. It also will suffer from a stunted growth. If there is an exchange from right to left, one can expect cyanosis. So depending again on the size of the defect, there are clinical signs or not. A second type of congenital cardiac malformation is known as common Truncus arteriosus, defined as one main artery leaving both chambers of the heart. The blood is injected in this common truncus from both the right and left ventricles via a high ventricular septal defect. This always is associated with a cyanosis. It is due to a failure of the septum to form a septum from this common truncus to separate this truncus into the aorta and pulmonary outflow tract. And also a complex cardiac malformation known as Eisenmenger's complex can be seen occasionally in young foals. Again, such a malformation always will be associated with cyanosis. A deviation of the mouth may lead to problems of suckling, obviously, as you can see here. A cleft palate certainly will result in the development of an aspiration pneumonia, particularly if it's affecting both the soft and hard portion of the palate. And indeed, this animal will always die because of a severe aspiration pneumonia, being characterized in this particular instance by a bilateral anteroventral involvement. One also can see milk aspirated into airways if one opens up the airway. Malformations associated with the musculoskeletal system are plentiful. Here we have a combination of a scoliosis and an arthrogryposis, and most likely also a congenital ventral hernia. This particular chap has arthrogryposis. Arthrogryposis being either the result of a faulty position of the skeletal system in utero. It also can be the result of a neurologic disorder associated with the spinal cord, or it can be secondary to hypothyroidism due to goiter. It is a situation that is caused by a variety of factors. Here again, an overextension of the frontal digit. If one looks hard, one can see in the area of the thyroid a bulge. This obviously could also be an enlarged lymph node, but in this instance, hypothyroidism does lead to dysmaturity of the musculoskeletal system. Hydrocephalus, an obstruction to the flow of a central nervous system fluid, leads to dystocia and incompatibility of survival, as seen in this little chap here. The marked doming of the skull being associated with a severe and constant fluid accumulation in the ventricles of the brain to induce atrophy, cerebral atrophy as well. A congenital skin disorder associated with Belgian horses is depicted here. It is known as epidermolysis bullosa, being characterized in the skin, as also sloughing of the epithelium associated with the oral mucosa. A congenital melanoma is seen here. And then one of the major congenital diseases is known as lethal white or aganglionosis. It occurs in white folds born to overo-spotted parents, and it is the result of a deficiency or total absence of myenteric plexi associated with the large intestinal tract mainly, but also with the small intestinal tract. It does, lead to meconium impaction that can actually result in a rupture and a release of meconium into the peritoneum. A nicely distended large intestinal tract characterized by the greenish meconium. And again, if one looks into the wall, one can appreciate that there is a paucity or total absence of ganglia. Another type of gastrointestinal congenital malformation is defined as Atresia coli, whereupon there is an interruption of the tributary of the large intestinal tract, and one portion is very, very rudimentary, the distal portion. The craniate portion is filling up with meconium, as one can appreciate in this particular specimen. Individual strictures to the passage of feces anywhere in the small and large intestinal tract may lead to focal expansion of the craniate segment. And here's the site of stricture. Atresia ani or recti leads to a absence of defecation, and actually, as one can see here, there is no exit to the rectum. Acquired diseases affecting the neonate. Every so often, a trauma leads to hard tamponade, as here, a kick by mother or some other horses, or any encounter with a very sturdy object can induce a fatal condition. And if one then looks at the site, there is evidence of myocardial fracture in this particular heart. Trauma to the head leads to fractures associated with the bones of the skull, as one can see here, and fairly significant hemorrhage, which can be also featured as contra-coup. In any of these cases, it may be fatal right away, or it may cause to some CNS signs in these animals. Here again, evidence of a significant extensive fracture associated with the skull and the associated hematoma associated with the cerebrum. Premature foals are suffering in many which ways. They're still, however, cared for intensively, and in some instances actually can make and survive. In some instances they suffer from lung problems and or problems associated with the spinal cord, known as Maladjustment Syndrome. In these instances, there is evidence of severe meningeal hemorrhage. There is evidence of septicemia due to a failure to suckle colostrum. Again, the situation with the spinal cord may only affect the meningeal surface, but may be severe enough to prevent this animal from standing up and suckle. Pulmonary changes are also quite frequent, starting with simple atelectasis, as you can see here. This resembles very much a fetal lung, and indeed it is. If one takes species from anywhere in this lung, they all will sink in water or formalin. And then failure to transfer colostrum or failure to develop the immune system leads to secondary pathogen as far as the lung is concerned. One of those is Adenovirus Pneumonia, typically characterized by a plum coloring of the cranioventral portions of a lung, an exudate and airways composed of neutrophils mainly, but if one looks then into the respiratory epithelium, the adenovirus inclusions are very plentiful, as seen here. This could be very well, again, a immune deficient Arabian horse suffering from adenovirus pneumonia. Bacterial pneumonias can be caused by a variety of gram-positive and gram-negative bacteria, organisms. Such a lung involved in such an inflammatory process needs to be differentiated from partial fetal atelectasis if one considers the neonate as the patient. This lung has multiple areas of consolidation characterized by plum coloring. The pneumonias can become or look rather inconspicuous in some instances on the surface. If one, however, cuts through the parenchyma, one can see the entire extension of the inflammatory gangrenous process in such a lung. Glossitis, as seen here, is many times associated with an overgrowth by Candida, but not necessarily as far as the young foal is concerned. Such a fibrinonecrotic glossitis can also be the result of a variety of bacteria. But if it is due to Candida, also known as thrush, one can expect in some kind of immunocompromise, and via touch prep or histology, the yeasts become readily evident with a special stain, such as done here with PAS. Enteric pathogens are a real threat to the neonate, the youngster. Salmonella is still a very pathogenic organism, causing a variety of changes associated with the small intestinal tract, as characterized here on the mucosal surface. being featured as a fibrinonecrotic exudate, extravasation on the serosal surface, signalizes endotoxemia, and indeed this is the case. It's not just the diarrhea resulting from a severe involvement of the intestinal tract that is fatal to the involved animal, but more or less the endotoxemia, clotting disorders, a response on the part of the mesenteric lymph nodes sort of suggests an attempt to cope with the intracellular gram organism. Usually it's Salmonella type B that is involved. The Endotoxemia Septicemia is featured in many of the surfaces of many organs, as seen here in the brain, in the meninges. The adrenal reacts very fast to the presence of endotoxins, in that there's extravasation into the cortex, known as Fredrickson-Waterhouse or Waterhouse-Fredrickson syndrome. It is seen here in this adrenal gland as well, in a minor extent, but nonetheless it does affect the cortex. The pericardium, the epicardium is involved as far as the heart is concerned, and even there may be hypopion as far as the anterior chamber of the eye is concerned. So salmonellosis is a very serious problem that not just only affects one of the animals, but it's ramping through the entire herd, and it's really a headache towards management and the treating veterinarian to cope with such a situation. So a quick diagnosis, a confirmative diagnosis is mandatory. The isolation and a check towards sensitivity, which drug to use as far as prevention of further outbreaks in the herd is concerned. Another bacteria enteric pathogen is Clostridium. Originally Clostridium perfringens, but lately Clostridium difficile. It induces a transmural hemorrhagic enteritis in the acute phase, and mainly it is acute, which should be differentiated from a small intestinal volvulus in this case, but this is a case of Clostridium difficile. It releases two toxins, an alpha toxin and a beta toxin. The alpha toxin is a lipopolysaccharide. The beta toxin is a cytotoxin, and either one need to be verified by ELISA or PCR to make the specific diagnosis of Clostridium difficile hemorrhagic enterocolitis. Other Clostridia, in addition to Clostridium perfringens, on occasion can cause a situation like this, are known as Clostridium Sardeli. Here again, once eviscerated, one can appreciate the transmural effect of Clostridium difficile. It causes microscopically a coagulative necrosis of the mucosa, which of course should be differentiated against autolysis, but this was a fresh case. And if stained specifically, one can appreciate the magnitude of the rods, gram-positive rods on the surface of such an affected animal. But 20 years ago, a paste known as Prima paste was given to foals to stimulate appetite, contained a component that was toxic to the liver. The component was known as iron fumarate. The animal suffered from severe total liver necrosis, and if stained appropriately or measured for an extensive extent of iron, was demonstrable in such a liver. The livers looked very collapsed in these affected animals, and indeed showed severe dissociation of hepatocellular plates and disappearance actually of hepatocytes and very little or no inflammatory reaction. These animals died very peracutely. Obviously, I guess it was due to the pathologists seeing these cases that quickly, or not so quickly, but ultimately identified this product as being the culprit, and it was taken off the shelves, and subsequently these cases have disappeared. But just for historical purposes, wanted to present this as a case of neonatal, peracute, acute, diffuse, lethal liver necrosis. A bacterial disease known as Tissus disease on occasion may involve the liver of neonates, difficult to discern, but nonetheless causing foci of necrosis that are in some instances confluent. They are better appreciated at the microscopic level as coagulative necrosis with a rim of inflammation. When stained specifically with Warfarin starry silver stains, Bacillus piliformis becomes evident. It seeds hepatocytes in clusters, very long hair-like organisms. This, of course, if not specifically stained, should be differentiated if it is a coagulative necrosis in a neonate from equine viral hepatitis type 1. Umbilical problems due to a faulty management after birth, faulty umbilical hygienics, lead to umbilicitis. Another problem is known as persistent urachus, leading to dribbling, constant dribbling around the umbilicus, and this then leads to a secondary inflammation, infection of such a constantly urine-stained umbilicus, also known as previous patent urachus, and it is seen here in this instance connecting with the umbilicus, and here are the uterine arteries. Rupture of the urinary bladder in male foals is an occasional occurrence, and it typically ruptures dorsally. The dorsal musculature must be somewhat weak in these male foals. It leads to uroperitoneum. Uroperitoneum is a very severe condition and does lead to death very fast. And again, a primary umbilical or navel infection can be also quite severe, but in certain instances leads to navel ill shigellosis due to the infection by Actinobacillus E. coli. Here is the kidney to show multiple small white foci in the cortex due to an embolic glomerulonephritis. And we'll come back later to this situation. Again, it starts primarily as an environmental disease associated with, again, a poorly managed umbilicus, and due to the patency of a ductus venosus, quickly gains access to the circulation, and the end organs such as the kidney are trapping a lot of these bacteria in the glomeruli. On occasion, such a situation may be not the cause due to Actinobacillus E. coli, but another pathogen, bacterial pathogen, leads to small white abscessations in the cortex here. This was a case of E. coli. The next was a case of Streptococcus aureus. Isoerythrolysis neonatorum, or isoimmune hemolytic anemia, results in both extravascular and intravascular hemolysis and develops when there is a blood group difference between the mare and the foal. The mare becomes sensitized to the foal's alloantigen, and hemolytic alloantibodies are concentrated in the colostrum. Clinical signs of icterus develop between 7 and 8 days. And here is such a case of icterus, severe icterus, as seen at the site of the visible oral mucous membranes. The entire body is yellowish discolored, certainly the serosal surfaces. And notice that this structure is green, and it ultimately will turn out to be the kidney. The kidneys are involved. We see the urinary bladder stains bluish, so there is evidence of blood in the urine, hemoglobin. And here is the kidney to show hemoglobinuric nephrosis, a tarry, very dark kidney, the threshold of hemoglobin resulting from the severe hemolysis causes the kidney to get rid of the hemoglobin into the urine, and the urine will show a burgundy red color or discoloration. Likewise, the intimal surfaces of the major blood vessels, or all blood vessels, undergo a yellowish discoloration, and even the cortex of this long bone will show the presence of biliverdin, basically, since it is green in the cortex. I would like to continue with primary immunodeficiency diseases, as they were typically seen to be associated with the Arabian horse, the Arabian foal. And here are some of the clinical presentations of such an affected animal, showing a conjunctivitis and maybe also a exudate around the nares, suggesting some evidence of a pneumonia, and indeed many times they had pneumonia in addition to other organ involvements. The disease was morphologically typically characterized by a paucity of lymphoid tissue in primary lymphoid organs, as seen here in the thymus. And the lymph node, most of these cells are structural cells. There is a total absence of lymphocytes around the periarterial sheath. And that sort of touched upon the cell-mediated arm of the immune system, but also these animals suffered from an appropriate development of antibodies, suggesting that both the cell-mediated and the humoral immune system was not functioning very well. Hematology typically then showed the scenario. This is a hematogram from one of such affected Arabian foal with combined immunodeficiency diseases, whereupon on the right-hand side the values clearly indicated a deficiency of white cells, white blood cells, particularly as far as the lymphocytic series are concerned, as compared to an expected normal value of such a foal. A very serious problem in neonate foals was due to septic polyarthritis. Here is such a very young horse involved in a scenario where multiple joints were clearly enlarged. Clinically, they were painful, they were reddened, and they then, upon opening, showed a variety of changes associated with the joint space, the joint capsule, and the articular cartilage. Septic polyarthritis may be, again, due to a failure of pasic transfer. It may be an indicator of a poorly managed umbilicus. It may be, as already indicated, due to pathogens, enteric pathogens. It may be also due to a hypothyroid state, due to hyperthyroidism, in many which ways, multifactorial, but very debilitating as far as the affected foal is concerned. A couple of examples make the point here. The head of the humerus shows a severe discoloration of the articular cartilage and clefting defects with a mirror image associated with the glenoid capsule. Typically, a lot of serosanguinous or purulent fluid was released, and a variety of organisms, particularly gram-negatives, were cultured from such an affected joint, or in many instances, multiple joints affected. Here, a situation where the acetabulum and the head of the femur showed the severe clefting and derangement of the articular cartilage. A inflamed and thickened synovium surrounds this joint, and again a lot of excessive joint fluid, purulent serosanguinous joint fluid was released from such affected joints. The clefting goes all the way into the through the articular cartilage into the area of the epiphyseal, into the epiphyseal cartilage as well, and one can expect a osteitis from such a process to develop in the epiphysis. And indeed, this is the case if one performs a sagittal section through such an affected bone. There is an area which is characterized by a yellowish discoloration and a reddish rim, mimicking an infarct. But if one would look microscopically, it will be characterized by the presence of neutrophils and other inflammatory cells. Dr. Alvin Firth from New Zealand suggested a model whereupon 3 types of septic arthritis could develop and defined them as S-type, E-type, and P-type. And I'll show you an example of each of these 3 types, depending on the involvement of the various structures, and this also has an impact on the severity of the clinical signs and the prognosis for such an animal. The first and the less severe type is the S-type, associated strictly and only with the synovium, and that's where the S-type is derived from, standing for synovial type. A synovial thickening, a velvety surface of the synovium suggesting inflammation, versus a virtually normal articular cartilage, which should be lightly blue. So this is probably prognostically one of the more favorable types if it's only affecting one joint to treat, but obviously one has to culture the culprit first in order to do appropriate treatment. The next type is the epiphyseal type, and it is characterized by the involvement of the subarticular cartilage, the epiphyseal cartilage, to show a inflammation in this area, which then can become severe and causing some collapse of the surface articular cartilage. The third and most severe type, and unfortunately also the one that is present most of the time, at least when these animals come to pathology, is the E-type, standing for the P-type, standing for physeal type, and it is affecting either side of the physes in a severe inflammatory necrotizing process that brings about a collapse of the physis and interference with growth if it extends and lasts for a longer period of time. It also extends into the area of the metaphysis and causes collapsed articular cartilage surfaces in many of these joints. Here again, a severe type of the P classification of septic arthritis or arthroosteitis, osteoarthritis, mimicking infarction, but this is just as very evidence of a very, very severe osteitis. And it may extend into the area of the bone marrow, affecting the entire bone marrow of this long bone, and it causes, in this instance, or has caused, the severe collapse of the physis. Many times, organisms such as Salmonella or Klebsiella pneumonia cultured from such affected joints. On occasion, it can be the result of a fungal infection, particularly certainly in my part of the state in Florida, where there's a lot of, where the climate favors fungal infections of various organ systems. In such instances, it can be an aspergillus or another fungus that one can demonstrate in the bone marrow or in the affected bones of such animals. Just to show a situation where there is a feature of what appears to be a degenerative joint disease, perhaps from such a septic polyarthritis associated with the olecranon. This is normal. Each and every horse, certainly the young horse, has this clefting. This is a synovial fossa. It should not be confused with the diagnosis of septic arthritis. In the early 80s, my institution had a high loss of folds, and this table sort of summarizes the organ systems that were most frequently involved in septicemia or bacteremia. The first one, again, clearly was the bone and where the bone and joints as outstanding. But as we will later on discuss, gastroenteric diseases, or had seen gastroenteric diseases, were a close second. And also the lung, the respiratory tract was involved in many instances, versus some organs being involved to a lesser degree, or disease syndromes. So this just gives a mathematical example of that the skeletal system, particularly the joint system of the neonate, is highly endangered as far as staying healthy and being highly susceptible to infection with a variety of bacteria, particularly gram-negative bacteria. The organism isolated from not just the joints, but other organs involved, such as the intestinal tract and the lung, are depicted in this table. Just to give an example, again, the gram-negatives seem to be high up on the list, but gram-positive organisms, including fungi, were also isolated. And then for a clinician or the owner, it's always important to obtain an appreciation of a prognosis. There are a couple of instances where the survival rates are good enough, and there are, however, areas where there is a very limited prognostic survival, and these are mainly characterized as prematurity, septicemia, and again, joint infection. So to make the long story short, a joint infection in a neonate is a serious problem to cope with, and in many instances does not lead to the expectation of such a fall, particularly if it's envisioned to become an athlete. This concludes the first category of neonatal diseases, or diseases associated with the neonate. This particular fellow certainly looks ahead towards the Kentucky Derby. It's just a representation of a healthy foal among all the diseases that I have been describing so far. It always, I think, behooves to show a healthy foal in this instance. On to the juvenile, and this is basically a group after 1 month all the way to 9 months perhaps, or even affecting diseases affecting them as yearlings. But the majority of the diseases affecting juveniles probably will range between 3 and 9 months of age, at least the types of diseases that I'm going to go presenting now. The first one is equine interstitial pneumonia, also idiotypic interstitial pneumonia, an enigmatic disease, but if it affects the juvenile, it typically may affect a foal that ranges between 3 and 9 months of age, though I have seen it in younger animals as well. The youngest probably about 3 days of age. And we are talking about the juvenile. There is an adult form as well that I will present later on when we are talking about diseases of the adult horse. The juvenile interstitial pneumonia is an enigmatic disease, but it can be defined as being the cause of alveolar damage, and the integrity of the alveolar capillary unit in the interstitium is the primary source for the development of that disease. Many causes have been hypothesized: infectious causes, toxic causes, chemical, allergic causes. None of them has been proven to hold up. So by and large, this type of interstitial pneumonia or pneumonitis in the juvenile horse is enigmatic. We do not know what causes this. It is characterized by a lung that does not collapse at all. It's very meaty on touch, on palpation. On cut section, it looks very much like the surface of a liver. It is mottled in this instance. And radiographically, if one subjects such a lung, shows a interstitial density in a diffuse fashion, and indeed that is the case. There are two forms, the acute and the chronic form. This is an example of the chronic form. The acute form is characterized by hemorrhage, extravasation into the alveolar space, and disappearance of the septum or septa. And notice the airway is uninvolved. Soon thereafter, hyaline membranes form to cover the necrotic septal areas. And as one can appreciate, there is a hypercellularity characterized by plump, more or less plump cells that seem to spin off, to sprout off the alveolar septum. And indeed, these are pneumocytes type 2 pneumocytes that proliferate to form the chronic phase. Again, hyaline membranes in the acute or subacute phase. These animals typically suffer from respiratory distress. They really literally gasp for air. The chronic forms are causing a consolidation of the alveoli. It is the result again of type 2 pneumocyte proliferation and some inflammatory cells, mainly being neutrophils. It becomes a denser picture. This is an adenomatoid hyperplasia of type 2 pneumocytes, forming almost a fetal lung. Again, this is also defined as fetalization. And it clearly becomes evidence that there is a shortage of airspace. And again, to emphasize, the airways are not involved in this process. This is strictly an alveolar disease. The etiology suggested, if they belong to the infectious category, suggested Rhodococcus equi, Pneumocystis carinii, Klebsiella pneumoniae, Salmonella, The influenza virus and the equine herpes virus have been suggested as being involved. In some instances, they were actually demonstrated. They were demonstrated by isolation, cultural or viral isolation, or immunohistochemistry. But it only involved a certain category of animals, not all of the animals. Many of the animals were simply sterile. They had a sterile lung. That then shifted the focus to the hypothesis, well, maybe it's an environmental toxin or a toxin. And there are a couple of plants that can cause the pattern of interstitial pneumonitis and pneumonia: Crofton wheat, perilla mint, paraquat, a wheat toxins, or simply pyrrolizidine alkaloids, or oxygen toxicity. All of these, yes, have been proven in these instances to cause interstitial pneumonitis, but in many of the cases, none of these were detected in the environment of the animal. Just to show you that Rhodococcus equi can cause an interstitial pneumonitis as a secondary change. The primary change always will be the presence of granulomatous pneumonia with the presence of giant cells or macrophages, and a demonstration of Rhodococcus equi as gram-positive intracellular organism in such an involved lung. I think either the release of products from Rhodococcus equi or sequela to the inflammatory response to the presence of Rhodococcus equi may induce the secondary pattern of interstitial pneumonia. Here is equine herpes virus being characterized by the presence of intranuclear inclusion bodies. So that can again be a cause in some instances of interstitial pneumonia. Likewise, Pneumocystis carinii has been thought to be the primary pathogen, but I think in my opinion it's probably just a secondary opportunistic organism that one can demonstrate as a secondary agent in a lung that, in addition to interstitial pneumonia, if it is Pneumocystis carinii, shows what's known as alveolar proteinosis as well, a protein-rich fluid that is also shown in the lumen of the alveoli. If it is an interstitial pneumonitis, other bacteria can on occasion cause diseases in addition to Rhodococcus equi. Here is such a lung to show Pasteurella multocida, with a marbled pattern, just like in cattle. But again, this could be also strep or staphylococcus, or even a variant of Rhodococcus equi. Speaking to Rhodococcus equi, well, this is a thromboembolic scenario, and then this is a pleuritis that in some instances can affect the juvenile. Speaking about Rhodococcus equi, this is the typical presentation. First the age, then the distribution, and then the presence of abscessations, multiple abscessations in Rhodococcus equi pneumonia. It's still lingering around every summer, at least in Florida, probably in other states of the nation as well. It strikes many outfits, many farms, many equine farms, and involves many youngsters. Larger abscessations, and even larger abscessations being result of multiple eccentric, locally extensive abscessations, quite extensively destroying sometimes the entire lobule of the lung. Typically it's a creamy necrotizing exudate at that level, causing some cavitation in the affected lung tissue, and then a plethora of gram-positive coccoid Rhodococcus equi organism, typically occupying macrophages but being also extracellularly, can be seen in specially stained lung section, but these organisms are also picked up clinically through lavage and being involved in Rhodococcus equi. Other sites other than the lung and the intestine, as far as the respiratory tract is concerned, may on occasion involve the nasal cavity. This appears to be almost a tumor, but it is a very chronic rhinitis affecting this site, one side of the nose, probably a purulent nasal discharge. And here again, it almost is a solitary lesion in some instances that then causes a severe cavitation and distension of the necrotizing suppurative parenchyma and a tendency to encapsulate this process. By the time this is the case, in many instances, the foal suffers clearly from a severe respiratory disorder and is put down. That brings then on the intestinal form of Rhodococcus equi, which is the second organ system that is involved. It shows, again, abscessations involved with the mesenteric and colonic lymph nodes, a very cobblestone-like thickened mucosa with ulcerations, craterous deformation of a thickened mucosal corrugation. It nicely also shows lymphangitis, distended mesenteric lymph nodes that contain lymph looking like a milk-like fluid, very crusty if one touches these areas, and following the tributary of the lymphatics. And here again a very severe lymphangitis, almost granulomatous, and indeed it is. One sees plenty of macrophages and Langhans type giant cells in these lymphatics, secondary to a primary enteric form. And then again, if one then specifically stains these, it will show a plethora of Rhodococcus equi. Obviously, a case like this does lead to the syndrome of protein-losing enteropathy. These animals not only have diarrhea, but they lose a lot of protein. Okay, I would like to continue with gastroduodenal ulcer disease as it affects the foal. The first slide depicts the clinical signs that can be appreciated if such an animal is involved. Characterized by diarrhea, colic, painful situations associated with the abdomen, bruxism, rolling, fever, pneumonia, and seizures. What are we talking about? Well, we are talking about a situation whereupon ulcers develop in the stomach or duodenum or in the esophagus. And in the 80s, again, a significant number of such affected animals came to necropsy. And this table sort of lists the distribution as far as the sexes are concerned, rather roughly the same. Again, the thoroughbred, but that is the breed that is very prominent in Florida, was involved in the highest of all the percentages, but it affected other breeds as well. As far as the age distribution is concerned, this lists the age in terms of months. As far as the individual numbers are concerned, sort of becomes evident that between the first and fourth month, most of these animals were affected. And this one is a listing of the animals that came to necropsy to show that quite a bit out of the total number had gastroduodenal ulcer disease. The site of involvement, ulceration and or perforation affected both the compartments of the stomach, the non-glandular stomach and the glandular stomach, and in some instances the duodenum, or non-glandular and duodenum, but as I mentioned, in many instances also the distal esophagus was involved. Just to show you the anatomy of the equine stomach. Again, there are non-glandular segments and a glandular segment separated via the plicate margin. There's a fundus area and a body, and there's a greater curvature. The esophagus and duodenum are very much in proximity. And it sort of is used to identify the site and determine the site and describe the site. But interesting, right from the very beginning when these ulcers were seen, the hypothesis and thought whether there is a role of Helicobacter species involved in the induction of these ulcers came into existence, and it was very, very difficult to prove, and in many instances the results were negative and very disappointing. And only lately some people collecting stomachs from horses at the slaughterhouse just to find the evidence of Helicobacter in the equine stomach were able to prove that indeed there is a certain species of Helicobacter that apparently normally, without being involved in the induction of ulcers, inhabits the fundic zone, versus the ulcers being mainly concentrated around the body. So that's interesting whether this theory, at least as far as the horse is concerned, the symbiosis or the cause and effect of gastric ulceration exists in a similar way as it has been postulated now for human gastroenterology. It's still in the air, it's still unresolved. Again, the thought to look for Helicobacter existed as soon as we found out about these ulcerations in the foal, but in many, despite even very consequent and severe attempts and long-standing attempts, we were unable to demonstrate Helicobacter. The pathogenesis then focused more or less on an interplay or a disruption of the acidity in the milieu of the stomach. It also centered around a disruption of the appropriate blood flow via interference with prostaglandin, local prostaglandin synthesis, and also some type of back diffusion of hydrogen iron. Also the role of bile, a influx of bile into the stomach, or even the role of bile in the induction of ulcerations of the duodenum were thought to play a role. In many instances it was undetermined, but what finally crystallized out as a possible cause were the application of faulty dosages of non-steroidal anti-inflammatory drugs, apparently to these animals for different reasons. Apparently the mucosa of the foal is higher susceptible to the toxic damage of these substances and interference of prostaglandin local synthesis as a protective substance towards mucosal integrity. Infectious agents such as viruses and bacteria, and even the role of Candida were seriously looked at, but many of these ended up with question marks. So I just want to show you a couple of examples of involved segments of the gastrointestinal tract. Here is the distal esophagus to show just islands of normal mucosa. Most of the mucosa is sloughed off, and indeed it's not only erosion, this is an ulceration crossing the basement membrane. The separation between erosion and ulceration of the gastrointestinal tract is whether the process of mucosal breaks crosses the basement membrane. If it does so, we are talking about an ulcer. Microscopically, the squamous epithelium has been sloughed off. There's some kind of cellular debris. And in some instances, one could specifically demonstrate the presence of Candida yeast with PS stain as seen here. As far as the non-glandular stomach is concerned, it's just like in the pig, whereupon large areas of the squamous cell lining were ulcerated, and in some instances actually also perforated. If one would look at the microscopy, it becomes evident that there are whatever normal squamous cell lining is left is clefted, and the defect is reacted by the formation of an early granulation tissue. And then the glandular stomach, once involved, shows multiple sites of such ulcerations. Some of them could be perforated, some of them could cause bleeds. And in these segments, it was quite evident that the ulcerations were associated or preceded by the formation of intravascular blood clots. That only could be best seen in, again, the glandular ulcers, or the ulcers affecting the glandular mucosa and also the duodenal mucosa. Here again, in the submucosa, a large artery showing a partial clot. Here apparently is a lymphatic that also shows a lymphatic clot. Here's another lymphatic that shows a clot. So thrombosis is certainly then the cause for the occurring ulceration, and that thrombosis might be the result of, or has been introduced or reproduced by treating and over-treating animals with non-steroidal anti-inflammatory drugs. Here a situation where both compartments of the stomachs were involved, and notice the green stain suggesting certainly the participation of bile. Whether this is secondary or even tertiary to the development of the ulcers, or whether this has actually an influence on the formation of the ulceration, remains to be seen as well. So there's still a lot of confusion and a loss in terms of reproducing precisely the pathogenesis. But again, in some of these instances, it is thought to be the direct result of non-steroidal anti-inflammatory drugs. And here's a scenario where one clearly can see in the kidney that this animal has been treated with non-steroidal drugs, anti-inflammatory, because of the presence of what we call papillary nephrosis. Another instance whereupon local prostaglandin synthesis is interfered by non-steroidal anti-inflammatory drugs. So if one looked hard, certainly one could find these instances where, as a hallmark for treatment with non-steroidals, the kidney showed papillary nephrosis, and then there is evidence of loss of squamous cell lining as far as the esophagus here is concerned. The more heartbreaking cases actually ended up with a peritonitis, severe peritonitis, and here's such the beginning of a peritonitis in a foal with a perforating duodenal ulcer. Fecal material is seen to leave upon pressure the stomach. In some instances, the entire abdominal cavity were contaminated with feces, and certainly the acid fluid from the stomach literally dissolved serosal surfaces. And if one looks at such a perforation, either from the stomach as here, or in addition through ulcerations of the duodenum, it clearly becomes a picture that this is a very severe process. Here again, when opened up, a perforation right at the margo plicatus, many more erosions and ulcerations in the non-glandular stomach, and then the surface, the mucosa of the duodenum also showed evidence of necrosis. Okay, I have a few more slides as far as duodenal involvement of ulceration disease concerned. This is a segmental presentation of what appears to be a necrosis, but it is an ulceration which transmurally almost went through the entire muscular layer towards the serosa, and these are then the sites that easily may rupture anywhere. If there is no rupturing, it certainly is the site for what in chronic situation leads to duodenal strictures and obstruction of the preceding duodenum for the passage of feces. Here's such a stricture, and in many instances these strictures can be multiple, seen at multiple sites. And if again the animal has survived the acute or subacute bouts of duodenal ulcer disease, it certainly may lead to impaction and to rupture of the impacted preceding segment preceding the stricture. Again, a scenario in a juvenile animal whereupon you have an area of a small intestinal tract showing what appears to be a hemorrhagic enteritis or blood staining, transmural blood staining. This could be very well a pathogenic situation, an enteric pathogen, but it is just a dislocation of that portion of a loop of a small intestinal tract defined as volvulus, just to show you a few more changes. Interstitials may have happened in the juvenile, and if they do happen in the juvenile, it's typically any portion of a small intestinal tract where one finds such an interstitial causing devitalization of the part of the portion of intestinal tract that telescopes into the other one. Chronic diarrhea without evidence of pathogenic bacteria or any evidence of a ulceration or a irritation to the mucosa, literally without any gross evidence, may be the result of strongyloides vesteri, as you can see here, a nematode that typically causes an irritation of the enterocytes and a proliferation of the mucosa that may or may not be seen. In many instances is not seen and appreciated at the gross level. So these animals are picked up either through fecal parasitic investigation, or if the infestation with strongyloides vesteri is severe enough due to diarrhea and protein-losing enteropathy. Ascarids are gone for most of the horses, as we will see, the adult parasites. But every so often a youngster may have one or two Parascaris aquarum adults in the small intestinal tract. I just recently had an instance where there were quite a few, as seen here, to cause an ascarid impaction. And on occasion, the presence of many ascarids may lead to peristaltic motions and rupturing and a fatal peritonitis due to penetrating feces penetrating into the abdominal cavity. Another occasional scenario is a vegetative valvulitis in a juvenile horse. And here was a juvenile horse to show the presence of, the gross presence of triple E equine encephalitis, Eastern equine encephalitis, and we will hear about it very, very soon. Just to show you that some incidental diseases affecting juveniles. Mainly I had 3 examples of compact diseases that affected quite a few when present, quite a few of these juvenile horses. Here's one that had a ruptured dens, a trauma. So very individual examples. And that sort of concludes the second category age group of horses, the juvenile age group. And I would like to continue with the adult horse. And I would like to systemically go through all the organ system, and I would like to start with the nervous system and to say a few things as far as a field applicable technique to remove the brain and spinal cord of a horse concerned. Not all of us have the luxury to have a confined necropsy arena where we have all kind of equipment available to perform such a procedure, particularly electrical equipment, which makes everybody's life fairly easy when it comes to the removal of the brain, and certainly when it comes to the removal of a spinal cord. But nonetheless, it can be done in the field as well, and it should be done in the field as well. And I would like to demonstrate one or two techniques where this can be done. So we'll start with brain removal, field approach, and also a few words as far as spinal cord removal is concerned. First of all, one has to remove, in order to make things easy, the lower jaw of a mandible, and that can be done through dissecting through the folds of the lip towards the pterygomandibular joint, and just after many dissection processes, open the pterygomandibular joint and remove the mandible that way, in order to create a solid platform for the head. And then one needs a decently long handsaw, and then this band-aid sort of describes the cut, and one only needs to make a transverse cut in the right location behind the eyes, the zygomatic arch, through the calvarium towards the brain, and one quickly then will end up with two halves of the brain that one can peel out with fingers or with scissors. So that's fairly easy, really, and one can actually obtain very well preserved brain tissue that needs to be fixed appropriately, and on it goes, really. So that's one technique, a transverse cut with a head really resting very well against a solid platform, concrete or something like this, or wood, and against a corner, in order to avoid a movement of the head during the process of sawing. The second way is again a transverse cut and a mid-sagittal cut, and then this band-aid also demonstrates a area that cuts through the nose in order, if one needs to investigate the nasal passages for evidence of pathology. So all of this again can be done with such a prepared head, without the lower jaw, and then the brain segments will look like this, and one can easily peel up the cerebrum, cerebellum, and the brainstem in one piece or two halves, and then decide what one needs to do. Many times for viral investigation, or rabies particularly, we need to send an entire half brain to the respective lab. The other one stays with us for saving tissue for various ancillary investigations, including histopathology. So that demonstrates two easy field applicable techniques to remove the brain of a horse without mutilating it. As far as the removal of a spinal cord is concerned, a good neurologic investigation in a conjunction maybe with radiographic investigation localizes the disease process in a certain segment. That's certainly the case as it relates to the wobbler. So one does not really need to remove the entire spinal cord, but just the cord associated with the cervical vertebra, and that is demonstrated here. One removes the entire set of cervical vertebrae in one piece and then makes a decision which area one is interested in. Typically, the warblers are reflected by a certain location in a certain segment of vertebral spinal cord, and then cuts right through the vertebra and immediately gains access to that segment of spinal cord that one can remove. And this is done actually in a non-solid environment, just some grass and leaves, as you can see here. It only requires a very sharp blade and preparation of the vertebra such that most of the meat is removed. And then one has a piece of spinal cord that then needs to be opened as far as the dura is concerned, and then appropriately fixed for the microscopic examination. One even actually can make a section through the vertebral canal in order to appreciate stenosis or any fusion or any fractures, if that is the case. So I think the localization, the primary localization of a disease process then decides which segment of the vertebral column one would like to saw through in order to get access to the spinal cord. And again, that can be easily done in a field condition as well, without the presence of a bandsaw. If one really wants to be very precise and careful, one can meticulously disarticulate the joints as far as the vertebral column is concerned, as you can see here, in order to get access to the spinal canal, the spinal cord, and also then the articular surfaces if one thinks of a fracture or chronic joint disease or OCD or whatever you have. Okay, just a couple of words as far as brain and spinal cord removal in a field application and field situation are concerned. I would like to then introduce a couple of primary degenerative diseases in the horse. This appears to be an artifact, but it was a true scenario whereupon a major portion of the cerebellum was characterized by various large cavitation that intercommunicated with each other, seen in a case of leukoencephalomalacia. This is a primary degenerative disease caused by fungi involved with foodstuff, and the fungus that is involved is defined as Fusarium moniliformis. It produces a substance, fomenicin B1, that interferes with the ceramide synthetase system that is involved in the formation of sphingolipids. So that's the pathogenetic process. It's rather an extensive process of necrosis or malacia, as you can see in these coronal sections, and it not only involves the white matter substance, but pretty frequently also the gray matter substance. So it's a pan malacia, encephalomalacia, rather than a leukoencephalomalacia, but that's how it is defined in the literature. And microscopically, it creates cavitations and clefts, a state of spongiosis due to the disappearance of myelin substances in the neuropile. There's a very, very meager response on the part of glial cells. It obviously causes neuronal degeneration. These animals hardly survive the attacks. It's quite an impressive scenario. It's obviously preventable in that one should attempt to store the feedstuff appropriately. Moldy corn is the one that is mainly responsible for leukoencephalomalacia. A focalized malacia is known as negropalatal encephalomalacia, in that it affects the substantia nigrum as well as the globus pallidum in such affected horses, and it is due to the consumption of yellow fistal star. And here we have a demonstration of such a event where there is a bilateral symmetrical malacia with cavitation in these affected horses. Again, yellow fistal star. Abiotrophy, cerebellar abiotrophy, is not appreciable at the gross level, but it affects the granular cell layer as well as the Purkinje cell layer of mainly Arabian folds. As it is not detectable at the gross level, it certainly can be diagnosed through good neurologic examination. Obviously, these animals present with ataxia. As a morphologist, one is forced to certainly look microscopically at the cerebellar tissue, but one can remove the cerebellum and weigh it, and if it is below a certain percentage as far as the weight of the comparison of the weight of the cerebellum and the cerebrum is concerned, one already can make the assumption that it is probably the result of abiotrophy or necrosis. And what happens is that in these affected cerebella, the Purkinje cell layer is very poorly visible. There's a loss of Purkinje cells. They're also disoriented, and if cut appropriately, the granular cell layer is also suffering from opacity. But it's basically the absence of Purkinje cells in larger areas of the cerebellar folia that makes a diagnosis of cerebellar atrophy. This is a recumbent horse in a pretty bad shape, and in the older days we called this growth poisoning because these horses typically were kept around areas where citrus pulp was collected for feedstuff, and it was thought maybe that citrus pulp was the culprit for as a toxin directly affecting the brains of these these affected horses. Well, to make the long story short, this was not the right answer to the diagnosis and pathogenesis of growth poisoning. It's now thought to be the result of creepy indigo. Indigofera spicata is a legume that grows in the southern portions of Florida. And Indigofera spicata produces a toxin known as inspicin, which is an alkaloid that has a similar effect as pyrrolizidine alkaloid from Crotalaria seniculum senkia on the liver. Basically, it's an hepatic encephalopathy that creates a horse like this, like other toxins affecting the liver of horses, as we will see. I just brought that up because we thought many times it is the result of direct influence on the CNS system by citrus pulp, but nobody could prove it. We just had a recent collection of about 4 to 5 horses affecting with creeping indigo poisoning. Here's one to show a very diffuse lipidosis, hepatic lipidosis. Here's another one that shows a necrosis of the wall of the central veins with some evidence of inflammation and a dropout of central lobular hepatocytes. Here is the periphery of the liver to show some inflammation of the portal triads with some influx of neutrophils into the sinusoids. And then here is the brain of one of these affected animals, and it shows actually what one expects in any case of hepatic encephalopathy, edema, neuronal edema, a type 2 astrocyte proliferation and gliosis. So I'll just put this into a disease of a central nervous system, knowing very well that the primary target organ is the liver and the brain is showing these signs, these clinical changes secondarily. Another example of a primary degenerative disease is the wobbler. And it is a disease that typically affects the fast-growing thoroughbred and manifests itself clinically about 1 year or 2 years of age due to proprioceptive deficits, lameness, ataxia, and on it goes. It's one of the 3 forms of degenerative equine myelopathy, but as such, as a wobbler, it is known as equine, or defined as equine vertebral malformation malarticulation. As I indicated, there are 2 forms. There's a dynamic form affecting C3, C4, and we see this dynamic form here, where there is a laxity as far as the stability of the joint is concerned. These animals, upon moving of the head, typically will impinge on the adjacent spinal cord of such a hyperrelaxed joint to cause then primary degeneration at that site. It's a dynamic stenosis, and it's quite impressive how severe it can be in certain instances. Sometimes you may have the instability due to a primary osteitis affecting a portion of the vertebral body in this area, but most of the time it is the result of a hyperextension that impinges on the adjacent spinal cord. So this is the dynamic form. The static form usually reveals itself between C5, C6, sometimes C6, C7, and it's a true stenosis, is true narrowing of the vertebral canal, as seen here. And it is actually a dorsoventral flattening that then chronically flattens the adjacent spinal cord. So it's a process that probably develops, it takes longer to develop, but it is more impressive, and it even can be appreciated grossly in the affected spinal cord. One always certainly passing a finger through the narrowing can appreciate the degree of such narrowing. Sometimes a wobbler results from chronic joint disease affecting the articular facet, or even OCD. So these are 2 other possible causes, in addition to a 5th, but they're very rare, some cysts associated with the dura or the epidural canal impinging on the spinal cord, causing compression and then focal degeneration. How does it look microscopically? Well, this is not the best of the representation, but good enough to define it as neuroaxonal degeneration. There is evidence of spongiosis, a spongy type of white matter substance. The spongiotic appearance or vacuolic appearance is a result of a loss of myelin and in some instances axonal swelling. And then there is a small response on the part of glial cells and macrophages to transform into Gitter cells, and this whole structure is known as digestion chamber. So this is the prototype of neuroaxonal degeneration or Wallerian degeneration as the older literature defines it. Again, we see this in the wobbler condition, but we also see it in a second type of equine degenerative myelopathy known as equine degenerative myelopathy, typically affecting Morgan horses, quarter horses, or standard-bred horses. And it's an obscure type of degeneration, thought maybe to be due to vitamin E deficiency. At least it apparently is responsive to treatment with vitamin E. Some people think it may be also a copper deficiency. Anyhow, it's familiar in that it affects quarter horses, standardbreds, and Morgan horses. And it is not the secondary or the result of a disease affecting the associated vertebra. So these animals will not show evidence of a wobbler or degenerative joint disease or whatever you have it, but they do show neuroaxonal degeneration. And a third time may happen sometimes in conjunction with anesthesia. It's known as post-anesthetic myelopathy. It also may affect the musculature as well, but as it relates to the spinal cord, it causes sometimes a very severe malacia in conjunction with hemorrhage, and it is thought that the dorsal recumbency results in major viscera putting pressure of nutritional artery to this particular segment of spinal cord. So it's thought to be the result of an hypoxic event, the result of hypoxia. It's rare, but nonetheless can be the result of more malacia than neuroaxonal degeneration. Equine motor neuron disease is the equine equivalent to Lou Gehrig's disease, and it is the result of degenerative processes associated mainly with the lower motor neurons of the spinal cord, leading to neurogenic myopathy or muscular atrophy, and that's the characteristic clinical signs of lower motor neuron disease, including in men. Here is a scenario where one can see a edema and a chromatolysis of neurons, loss of nuclei, no reaction basically, so it's truly a degeneration of neurons. And here is the associated muscular atrophy with the girdle and the hind legs. And that's actually the sign of lower motor neuron disease. It basically has been described in the Northeast with rare cases seen in other part of the nation or in Europe. So it seems to be geographic somewhat, and it also seems to affect the standardbred. On to primary inflammatory diseases, starting with virus diseases. There's one or two or three viruses that create fulminant clinical signs with already clinical suspicions of being involved without showing gross lesions. The first is rabies. A rabies-affected horse may be a silent rabies or maybe a very vicious case of rabies whereupon the horse is seen to eat something like brooms, certainly attacking and so on and so forth. And yet no signs of any gross lesions affecting the brain and or the spinal cord. And even microscopically, it's a disease that is not really characterized by much of pathology. It's almost very disappointing to see a very mild perivascular lymphocytic infiltrate, and that's about it. In the area of the hippocampus here, maybe a little bit of glial cell proliferation, but one has to be very careful in not falling into the trap that this is the normal architecture of glial cells associated with neurons. Luckily, the diagnosis for a pathologist is made by finding Negri body inclusions, in the cytoplasm. As far as the horse is concerned, it's not difficult not to see them. They're easily recognized. Here's one. So rabies is still with us, and depending when where the reservoir is, it's in my part in Florida, the raccoon, but it can be also skunks and foxes, obviously. A second viral disease that usually does not show growth signs is triple E, equine eastern encephalitis. It's a flavivirus, an arthropod-borne flavivirus that is mosquito transmitted. In Florida, it is seasonal, but it can be seen around the year with the peaks in the summer months. And only on very, very rare occasions, as seen here, can one appreciate triple E being characterized by the reddened meningeal or brain surface, which is active hyperemia. These are arteries that are distended by red blood cells. One can similarly see the distension of arteries on cut sections in various portions of medulla and the spinal cord. Again, to emphasize, this is a rare finding. Usually one sees nothing at the growth level as far as triple E is concerned. In the history, obviously a lack of a regular vaccination program, but more importantly, these animals are severely hyperthermic. They have fever all the way up to 104, 105 degrees Fahrenheit. That's a good piece of history given to the pathologist and together with other signs. What is it microscopically that one's supposed to see? Well, like many of the neurotropic viruses in many of the mammals, including the horse, where a viral encephalitis or encephalomyelitis is equated with a lymphocytic infiltration. This is not the case as far as triple E is concerned. This strain, this variant, has a neutrophilic component. So neutrophils are clustering around blood vessels and also invade the neuropile. Very important to remember. Obviously, in these days, viral isolation isn't necessary anymore, or determination of a titer. Pathologists like to demonstrate the agents directly underneath a microscope. So immunoperoxidase quickly will reveal the presence of viral antigens in neurons, and the neurons only, and in neurofibrils. And it's not difficult to subject a triple E brain to specific antibodies. It stains readily. There is a variant that we have been watching characterized by eosinophils rather than neutrophils. It's an eosinophilic meningoencephalitis, which is also thought to be due to triple E virus. And on occasion, one can see a lymphocytic myocarditis, and when subjected to immunoperoxidase, it clearly demonstrates that it also contains flavivirus antigen. On to the next virus, which is the West Nile virus. An episode or a viral disease that entered this country somewhere in 1999, and the first cases, in addition to human cases in the horse, were demonstrated in the northeast corridor. Subsequently, a year later, it hit the naive population of horses in Florida, and we saw our cases in Florida as well. Muscular fasciculation, in addition to other CNS disorders, but muscular fasciculation apparently are standing out as far as main clinical signs are concerned. What can the pathologist expect? Well, at the growth level, it can be very severe or non-visible. Here is an example of a severe hemorrhagic event affecting mainly the gray matter substance, but also the white matter sepsins, mimicking very, very much what we have been seeing in EPM. So the West Nile virus is very difficult probably to sort out clinically against the protozoal disease in my book. And maybe a third one that should be added to the list of differential agents is herpes virus, Equus herpes virus, that also can cause a hemorrhagic myelitis as seen here. But nonetheless, this is a representation at the growth level of West Nile virus infection. These changes are better seen at the level of the lumbosacral area of the spinal cord rather than craniate, but it varies. It's a more severe type of inflammation, and it's typically lymphocytic. Lymphocytes are arranged perivascularly around many of the blood vessels, but also stream into the neuropile. So a lymphocytic meningoencephalomyelitis. If it affects the brain, it's a polioencephalitis. In some instances, one can appreciate also glial nodules. But again, the diagnosis is made by viral isolation, PCR, or immunohistochemistry. I have seen West Nile also having a neutrophilic component. So that makes it not really easy to sort things out, just mere and didactically by establishing morphologic criteria. And it also induces nothing but mere hemorrhage, frank hemorrhage, something that you see in equine herpes virus myelitis. Again, this is West Nile virus myelitis. The best thing is then to demonstrate viral antigen via immunohistochemistry, monoclonal antibodies. It's not easy to do so, unlike EEE, but nonetheless a good lab can demonstrate the distribution of viral antigens in fibrils. That brings up a third disease that is not present in the Western Hemisphere in the United States, known as Borna disease. Borna disease is, like rabies, a negative-stranded, single-stranded RNA virus that has been described in Europe. The first description were coming out of Czechoslovakia, therefore the name Borno. Borno is a city in Czechoslovakia. It affects horses. It has a reservoir in rabbits and it has a reservoir in sheep. If a horse is involved, it typically has a lymphocytic encephalitis, encephalomyelitis, and it can be also causing neuronophagia and glial nodules. But luckily, if one looks hard enough, one can see inclusions. We used Degen inclusions being typically intranuclear. This may be not the best of the examples, but nonetheless, it's an inclusion. So like rabies, inclusion bodies can be found in Borna disease. A better detection method is, again, immunohistochemistry to show the presence of viral antigens in the cytoplasm, but also in glial cells, which is typical of Borna disease, and here again in glial cells. Equine herpes myelopathy, I do not have that much experience with. It typically is equine herpes virus type 1 involved. Outbreaks have been reported in stud farms, in breeding farms. It's unlike all the other herpes virus, and even including the equine herpes virus, a virus that apparently affects the integrity of endothelial cells to induce hemorrhage in a symmetrical fashion. It's sort of the hemorrhage follows the tributary of the vessels. And unlike the equine herpes virus somewhere else, or other equine herpes viruses, or other herpes viruses in the brain, don't expect to see herpes virus inclusions. The nice typical herpes virus inclusions that make the diagnosis is simply not present in herpes myelopathy of the horse. And just to be complete, the disease being gone or almost gone, swarm fever or equine infectious anemia had in some instances, or some strains had an affinity to the brain and caused an lymphocytic encephalitis, meningeal encephalitis. I would like to continue with equine protozoal encephalomyelitis, and this is my first slide to show a focal involvement of the spinal cord characterized by hemorrhage. Here is a coronal section through a portion of L6 to show a similar scenario very focally in the spinal cord. We already have seen that in West Nile virus myelopathy. Here again, it can be seen in equine protozoal myelitis. As a matter of fact, before we found out and studied the pathogenesis of this protozoal diseases, in the older days, the disease was identified as segmental myelitis, and that exactly makes a point. These foci of hemorrhage are segmental, randomly throughout the spinal cord, but segmental. Again, microscopically, the inflammation is quite impressive. At first glimpse, one again may think that many and most of these cells are lymphocytes, but they aren't. If one goes a little higher, it becomes evidence that they are macrophages interspersed, occasional multinucleated giant cells, and eosinophils. So it's a mixed inflammatory population that should make one aware that one should look for the culprit, which is a protozoan defined as Sarcocystis neurona. The horse is the dead end for Sarcocystis neurona. The opossum now is considered to be the definitive host. So could be the raccoon or the armadillo, but mainly it is the opossum that functions as definitive host in the life cycle of Sarcocystis neurona spread. And a variety of avian species are considered to be intermediate hosts. Again, the horse is a dead-end horse. When left untreated, and this disease is treatable, one fortunately can identify the organisms arranged in nests composed of banana-shaped merozoites that may be seen in the neuropile, or even better in cells such as macrophages and even neurons. Once the animal is treated, the organisms are much more difficult to identify, if at all. What may help is immunohistochemistry. Again, we are looking at a specific monoclonal antibody generated against merozoites to show the magnitude of clusters affecting neurons, but also most likely glial cells. And here again is the conglomerate of individual merozoites forming such a cystic structure. Electron microscopic investigation has helped to categorize the Sarcocystis into the family of Epicomplexa. And once more, it took quite some time to decipher the life cycle, but once more, the horse is a dead-end host, the definitive host is the opossum, and various avian birds are intermediate hosts. Individual bacterial diseases may be quite severe. The nidus is somewhere else, but here is a scenario of a purulent meningitis that happened to be caused by Listeria monocytogenes. Yes, Listeria monocytogenes can induce an encephalitis in horses. Cytology easily revealed intracellular and extracellular small rod-like gram-positive structures. Streptococcus equi, Varieties equi or Streptococcus equi, Varieties zooepidemicus in younger horses may cause nasty abscessations anywhere in the brain. Cns parasites. Well, they happen to be gone, but when equine parasites were still a problem associated with the equine industry, a couple of them were seen to migrate and involve the central nervous system, one of which was Strongylus vulgaris. These are migration tracts. Every so often the larvae died, became encysted, and caused the destruction of a larger area of the spinal cord. The one that on occasion still may be found and be the cause of ataxia is Helicephalubus Gingivalis, a rhabdiform nematode that occurs sporadically around the world, and when it does occur, the larvae and adults are typically affecting the cerebellum as far as the brain is concerned. We shall see later on the kidney, on occasion the gingiva, on occasion it can be involved in a mastitis as it has been described in the literature. As it applies to the cerebellum, the larvae can be easily identified. The adults are apparently only female and characterized by eggs and a rhabdiform esophagus. Here is the rhabdiform esophagus, and here are some eggs in the distal portion of the adult. It is thought that pathogenetic replication is maintaining the population of female adults that lay egg and larva develop in the affected organs. The parasites are quite destructive, such that major areas of the cerebellum are undergoing necrosis and inflammation. And then finally, Cauda equina, affecting the very distal filum terminalis of the horse, causes hind leg paresis paralysis, problems defecation and urination, and the very distal spinal cord nerves are involved in a thickening, and the thickening is a result of a granulation tissue that impinges on the nerves, and the granulation tissue is characterized by macrophages, lymphocytes, and giant cells. It is enigmatic, a disease as to the pathogenesis. It is thought it may be an immune-mediated disease in that there is an immune cellular reaction against basic M protein antigens in the spinal cord nerves. A couple of oddballs, cholesteal granuloma or cholesteatomas, are grape-like structures in the lateral or fourth ventricle of older horses with no clinical significance. They are large enough to think that they may cause obstruction to the flow of CNS fluid, but this is not the case. They're typically incidental. A type of neoplasm that occasionally may affect the epidural space of the spinal cord is a plasmacytoma or a hemangiosarcoma. This was a hemangiosarcoma. By and large, primary neoplastic growths, as described in other mammalian species, are very, very rare as far as the CNS system of a horse is concerned. Trauma. The effect on an involved animal depends on the severity, the speed, and the direction of the trauma. The most susceptible portion, as far as the head is concerned, are the flat bones associated with the spheno bones, spheno-basilar bones, and the arrow indicates a thin fracture line with the penetration of the edge of the fracture towards the brain to induce a fairly large hematoma. It really requires a significant impact for such a trauma to occur, but nonetheless, in cases of rearing, these are the portions of the bones of the calvarium that undergo fracture to cause a fatal hematoma. Other sites may be the dents of C2, that fracture, or occasionally a vertebral body, but these instances are fairly rare because of the fact that major muscular groups sort of protect this part of the vertebra from direct impact. So if a fracture occurs in these portions of the spine, some kind of underlying pathology should be expected. Here again, a complete fracture through the vertebra. On to the respiratory system. A case of warts associated with the muzzle of a horse. The wart virus can affect these portions, very rare, probably an underlying immune compromise to be expected. Sources for epistaxis are threefold, in my opinion. One is directly emanating from a hemorrhagic event in the nasal cavity. As you can see here, this actually is a hemorrhagic rhinitis due to either a trauma or a fungus. In Florida's climate, arid climate, fungi frequently become pathogens to the nasal cavities and structures of the nasal cavities. Here is a caseating rhinitis due to aspergillosis, a fungal rhinitis. Tumors distorting the nasal passages and or the head are of a variety of cellular lineages, starting in a younger horse with tumors associated with structures of the teeth, the dentine or cement. In older horses, it can be derived from nasal passages, from the epithelium belonging to the nasal passages, or the mesenchymal tissue. So we have squamous cell carcinomas, we'll have fibrosarcomas, osteogenic sarcomas, chondrosarcomas. It depends really on the histologic diagnosis. Just a couple of primary nasal tumors. They are not so rare as one might think. The more horses one necropsies, the more nasal tumors one sees. Here was the most recent one, distorting quite a bit of the nasal passages and being characterized by polycystic structure. This microscopically turned out to be a cementifying fibroma, something analog to an apulus in the dog. So one always needs to look at these neoplastic growths microscopically in order to sort them out. Here is a Mixo Sarcoma, being quite destructive, as one can see, occupying one half of the nasal passages and deviating the nasal septum. Here's another one being quite destructive. One that acts like a tumor but morphologically is not defined as a tumor is known as progressive hematoma. This may be the second source for epistaxis in the horse. A progressive hematoma is a excessive exuberant type of granulation tissue, most likely arising from the ethmoid bones. It is locally invasive and can distort the nasal passages quite intensively. It's very difficult to treat. Nonetheless, excision is attempted, and excised pieces suggest that they contain a lot of blood and blood vessels, and indeed that is the case. If one looks at them microscopically, they contain very plump fibroblasts, mineral deposits, neutrophils, angioplasts, very immature capillaries. They lead to local hemorrhage, being hallmarked by hemosiderin-laden macrophages, as you can see here. And again, as I say, one cause for epistaxis as well. A third cause is associated with the guttural pouches. The guttural pouch is also known as auditory diverticulum, and a unique structure to the horse. It connects with the ear as auditory tube, and indeed is a very distinct bilateral somatical pouch, intimately associated with the distal head, in particular the condyles. And it is prone to hemorrhage, inflammation, that can be quite severe. Here is a scenario where one or both pouches are filled by clotted blood. If one removes the blood clot, it becomes evident that one pouch is involved in a cauliflower-like exudate that is very brittle and is thought to be the result of a associated primary fracture of one of the stiohiatal bones. And here is such a macerated specimen to show a bilateral fracture of a portion of a stiohiatal bone apparatus. This is the source for an irritation and anitis of saprophytic fungi to become opportunistic and pathogenic. These fungi are typically either mucor species or aspergillus species, and they have a tendency to erode the internal or external, but mainly the internal carotid artery, which cruises through the guttural pouch and is closely associated with the bones of the stiohiatal apparatus. So this is the spiel, basically, or the set of pathogeneses that leads to what's known as mycotic guttural pouch disease, which is the end product. We have seen also Pythium insidium, a algae-like organism belonging to the family of Parasitida, be involved in guttural pouch mycosis. And we will revisit the presence of that organism in other organ systems very soon. Here is a ghost-like structure of Pythium insidiosum, which reacts with all the fungal stains, but is not classified as a fungus anymore and characterized as broad, non-septate, broadly branching hyphae. Guttural pouch empyema is caused by a combination of gram-positive bacteria, inspissated pus, and pus-like stone formation to really impact one or both of the guttural pouches, interfering with respiration and food uptake. Here is a section to show the inspissated pus and the calculi, stone-like formations, also known as chondroids. They look like stone, they feel like stone, they are hard like stone, but they are thought to result from inspissated purulent material. Pleuritis or shipping fever syndrome disease can happen in horses that are transported over a longer distance, and they are quite impressive as far as the severity is concerned. They cause severe adhesions between the visceral and parietal pleura, and a big and huge volume of purulent material being partially inspissated or partially fluidy in one side or the other side of the chest as well. Usually by the time these animals come to pathology, both sides are involved. Expect gram-positive organisms, Staphylococcus, Streptococcus, Pasteurella. Also expect an underlying lung disease. As a matter of fact, this underlying lung disease may be the immediate cause for pleuritis to develop. The lung disease is usually an abscess that grows towards the visceral pleura and ruptured into the visceral pleura. And in some instances, one still can see that the abscess per se is empty in that it has released a lot of purulent material into the chest. It has a capsule still. In some instances, adjacent areas still show the abscess in situ if one opens it up, and it is sealed by a fairly dense capsule that, however, may give away and release purulent material into the chest. Very rarely is it an external source, such as a piece of wood that penetrates the chest and ends up as a bridge leading many bacteria from the outside into the chest to develop a pleuritis. Heaves is a result of chronic obstructive airway disease. Small airways are mainly involved. There are two forms. One is the obvious visible form where air is concentrated within alveoli, within the interstitium, and also on the pleural surface. The second form is the one that does not contain excessive air grossly, but reveals itself by the presence of rib impressions, to somewhat suggest that it is a lung-filling event, and that lung-filling event is excessive air and mucin associated with the small airways. So this also is defined as chronic obstructive lung disease. A mucinous substance filling the lumen of bronchioles and bronchi, and an inflammatory peribronchial infiltrate being composed of lymphocytes and eosinophils. In this instance, suggesting a immune response, some kind of allergy to which the lung of this animal has been exposed and reacts by. Here is a bulla in a case of grossly visible emphysema, pulmonary emphysema, and notice that the interstitium is aerated, excessively aerated as well. On to then a idiopathic disease known as exercise-induced pulmonary hemorrhage. This actually is another form that in some instances may lead to epistaxis. So there are altogether perhaps 4 instances where epistaxis may arise from. The 4th one is the most distant one. Let me repeat. The first one may be a hemorrhagic rhinitis. Then we have ethmoid progressive hematoma. And then we may have hemorrhage associated with a guttural pouch to induce epistaxis, and this is the 4th one. This is typically seen in exercising horse, and it is defined as a bleed from the pulmonary vasculature. As I said, it's a small airway disease with reversible stress failure or breakdown of pulmonary capillaries due to increased cardiac output during exercise. Many times these animals just bleed from the nose, it disappears, they race again, maybe with a handicap in one way or the other, and the episodes disappear, they may reappear. In some instances, the animals are severe involved. And here's such a lung to show severe hemorrhage that is spotty, but also locally extensive. As you can see here, we see rib impressions. It is frank hemorrhage into the parenchyma. Here even more severe. A non-collapsed, very wet, very moist lung, suffering from exercise-induced severe pulmonary hemorrhage. It becomes really very nicely and obvious on cut section that major areas of the lung parenchyma, particularly the alveolar parenchyma, are involved. Again, the process starts at the level of the capillary, apparently. Looking at such a lung microscopically, it is characterized by a lake of blood extravasation. In the less severe involved animals, you may see hemosiderin-laden macrophages, which these are not. This is a fixation artifact, hematoidine pigment, but one's supposed to see the previous bouts as evidenced by macrophages containing hemosiderin. One can see capsular fibrosis, as well as a healing residual process, but in the fatal cases, major portions of the lung are involved in hemorrhage. This could be very much exercise-induced pulmonary hemorrhage, but this is DIC as a differential diagnosis and an overlap to it. This results from some kind of infectious process somewhere else where the lung undergoes DIC. This brings up then the adult form of idiopathic interstitial pneumonia. It affects horses around 6, 7, 8 years of age. I've seen it as young as 2. It is again a lung that's characterized by not being collapsed at all. It's a very stiff lung. It stands by itself basically. It feels very firm and meaty on touch. On cut section, it may have some gangrenous changes as well. We'll talk about it and have some better examples later on. This is a lung that suffers from mineral oil inhalation. So that would be defined as mineral oil pneumonia. And I personally feel that this may be the precursor of the adult form of interstitial pneumonia. I have no proof, but it may be a smoldering event whereupon mineral stimulates the lung tissue to cause the changes which make it an interstitial pneumonia. Because after seeing quite a few of these, in some instances one still can see residual mineral products that stain positively with oil red O. Here is a more acute form of mineral aspiration, clearly showing the presence of mineral. Rib impregnation are important to see in any type of pneumonia. Here we'll have pneumonia resulting from Pneumocystis carinii, again, probably a secondary opportunistic pathogen that in some instances can be seen secondary to the presence of idiopathic interstitial pneumonia, the adult form. Here again, a very heavy and meaty lung. Here to show some hemorrhage, but these are the acute forms. When we see the lung, it's a lung that looks that it just stands without being collapsed, and I'm at the end of my presentation.